our next speaker. This is Dr. Muniza Mogri. Is that how you pronounce it? Okay, perfect. So she's here today from Children's in Dallas. She did her medical training at Aga Khan in Karachi, Pakistan. Did her residency and fellowship at Children's Women's Hospital in Buffalo, and then worked at Janet Weiss, I believe, in Pennsylvania for a while before coming to Dallas. Very happy to have her. Her interests include, of course, bone health, calcium and phosphorus, homeostasis, and most recently, DiGeorge. And so we're very happy to have her talk about bone health once we get her slides pulled up. So thank you very much, and let's introduce her.
Good afternoon, everybody. I must say I'm very happy to be here today to talk about Duchenne muscular dystrophy and bone health. Hopefully the slides will come up soon. The reason why I chose this topic was because, Duchenne muscular dystrophy is a disease that sets in very early in life. Most of these patients are diagnosed before the age of 5 years, and they face a lot of physical and psychosocial challenges. And I feel we as a pediatric endocrinologist can make a significant impact on their quality of lives. And these patients and their families are really happy with anything that can make their quality of life better. So hopefully, waiting for the slides, we'll try to keep everyone awake since this is the last talk of the day. So we'll just hold on. All right, so I have nothing to disclose in relation to my topic today. The learning objectives will be to understand the disease pathology and effect of disease on bone health in patients with Duchenne muscular dystrophy, recognize the direct and indirect effect of glucocorticoid therapy on bone mineralization, apply bone health screening tools to detect early decline in bone health in patients with Duchenne muscular dystrophy, assess various steroid regimen and predict effect on the bone health, use bisphosphonate therapy in a timely fashion to prevent further decline in quality of life of patients with Duchenne muscular dystrophy, and learn about alternate bone protective treatments for patients with DMD. So like I mentioned before, DMD is inherited as X-linked from mom, and it's a recessive disease. So it usually affects, almost always affects boys, and the mutation is in the short arm of the X chromosome at location 21-2. There's impaired production of dystrophin protein, which results in breakdown of the muscle cells. The dystrophin protein basically stabilizes the cell membrane of these muscles when you're contracting or relaxing them. An absence of this protein results in muscle fiber breakdown and an inflammatory response in these patients. Initially, the proximal muscles are affected, and so you'll see these patients present with difficulty climbing stairs, squatting, resulting in pseudohypertrophy of the distal muscles, which is usually the calves are very significantly enlarged. And eventually, the disease progresses to the distal muscles and then to the core, resulting in cardiopulmonary arrest. And that. So how does Duchenne muscular dystrophy affect bone on its own? So when you have that inflammatory response because of the muscle breakdown, the cytokines release result in decreased bone formation because of increased inflammation. And then there's the Wolff's law, in which the decline in muscle strength decreases the muscle loading, and that decreases the stimulus for bone formation and creates increased breakdown of the bone. So if you look at the muscle bone unit as a whole, there's a lot of biochemical crosstalk. The decline in muscle strength results in diminished loading. The local inflammatory response results in decreased bone formation. And the steroid therapy, which is the mainstay of treatment for these patients, has both direct and indirect effect on bone formation. The direct effect is glucocorticoid effects, which I'm going to come to in a little bit, but indirectly, it also suppresses growth hormone release and transcription of IGF-1. IGF-1 is very important for synthesis of collagen-1. It also decreases the degradation of collagen-1 and apoptosis of osteoblasts. So the IGF-1 is very important for bone health. The glucocorticoid itself suppresses the bone turnover, and overall effect is low bone mineral density. So what's the clinical consequence? So you see these patients, they have very thin, weak gray cell bones. They're at high risk for lower extremity long bone fracture, and low trauma distal femur fracture is a classic manifestation of this disease. What are the other factors in Duchenne muscular dystrophy that are affecting the bones? So it's not just the steroid therapy, but there is also other risk factors: poor mobility and poor weight bearing. The posture on its own in these patients affect the bone health, and I'm going to come to that too shortly. The increased rate of falls because of low bone muscle strength. The steroid therapy results in delayed puberty. And also glucocorticoids decrease the calcium absorption. The steroid directly decrease the calcium transporters in the duodenum. So these patients, even though they take dairy and calcium supplements, the absorption is much lower. And they're also known to have insufficient vitamin D stores because of they're not these normal kids who are going outside and playing in the sun. They have very low sun exposure. They also have less bioavailable vitamin D because they're usually overweight and obese. And we know bioavailable vitamin D is lower in obese patients. And there's also decreased absorption. Long bone fractures occur in about 60% of these patients, and a glucocorticoid doubles the risk of long bone fractures and in fact triple the risk of vertebral fractures. Low trauma fractures have been reported even prior to diagnosis, so the disease itself is playing a role in decreasing the low bone mineral density. Femur, tibia, and humerus are the most common sites, and an antecedent long bone fracture predicts prevalent vertebral fracture 4.5 years after initiation of glucocorticoid treatment. It's interesting to know that the vertebral fracture that you see in these patients are asymptomatic, and eventually they can lead to progressive collapse and vertebral fracture cascade. There are no reports of these vertebrae body reshaping in absence of bisphosphonate therapy. So overall, you have a perfect storm for bone fragility. The DMD-related risk factors, which are progressive myopathy, loss of ambulation, frequent falls, the direct effect of high-dose prolonged corticosteroids, and then the low estrogen state and the low growth hormone state that we see in these patients. These patients gain a lot of weight, and they have growth suppression and low IGF-1 gene transcription. So if you look at the bone architecture, and this is a PRQ-CT scan to look at the trabecular and cortical bone, healthy boys at baseline have about 30 to 50% more trabecular bone mineral density, which you see right here. And also they have thicker cortices compared to patients with DMD. At 2-year mark, when you compare healthy boys to Duchenne muscular dystrophy patients, the trabecular bone is 27% less in ambulant DMD patient and about 53% less in non-ambulatory DMD patients compared to healthy boys. The risk of fracture begins at a very young age, and it continues to rise after loss of ambulation. And non-ambulation independently increases the risk factor of fracture by 75%. And there's an 80% probability that these patients will have a fracture by the age of 20 years. So how do glucocorticoids affect the bone cells? So there's an acute phase in which you see increased osteoclastic activity. There's decreased apoptosis of osteoclast, increased osteoclastogenesis. There's increased production of rank L and increased expression of serostin gene expression. All of that results in increased bone resorption. In the chronic phase, you start seeing there's also low bone formation. Steroid therapy induces signals from the osteoblast, which results in the precursor cells to be differentiated into adipocytes rather than the osteoblast. So these bone cells are invaded with adipocytes, and most of the bone mass is gone, and there's a lot of fat cells, and these bones get weaker. And there's lots of osteocyte toxicity, which results in reduced bone mass and strength over time. So if you see vertebral fractures can be initial manifestation of the glucocorticoid bone disease. And like I said, they could be atraumatic and asymptomatic and just be picked up by spine x-rays. If this progresses to multi-level fractures, these patients are in a lot of pain. They have it also results in kyphosis and scoliosis. A vertebral fracture can occur as soon as 6 to 12 months after initiation of glucocorticoid therapy, and that's why screening is very important for these patients. How does changing the steroid regimen help? So if you see daily prednisone and daily deflazacort regimen have a much higher cumulative hazard compared to intermittent prednisone and intermittent deflazacort. However, this comes to the expense of muscle loss. So if you see the rise from floor velocity is much lower in patients with intermittent steroid versus daily steroid. And at the end of 3 years, there's a significant decline in rise from floor velocity. So it comes at the expense of disease progression. There's definitely less vertebral fractures in patients on intermittent steroid therapy compared to daily, and it's about 5 times less. So if you see here at 2 years, patients on daily prednisone, the fractures are 4% versus 0%. At 3 years, it's 20% versus 4%, 40% versus 3% in patients with daily versus intermittent steroid therapy. How does posture affect the bone? So if you look at the patients with Duchenne muscular dystrophy, in the ambulatory phase, because of the proximal muscle weakness, there is a compensatory change in posture, which results in hyperlordosis. This results in anterior slipping of the vertebrae called spondylolisthesis, and that results in vertebral fractures. In the non-ambulatory phase, there is loss of lordosis. So if you make these patients lie down, this is how hyperlordosis looks like, and this is how loss of lordosis looks like in the ambulatory and the non-ambulatory phase. How does that affect the weight distribution? So if you see a neutral spine, the weight is distributed more centrally versus a patient with hyperlordosis, which is DMD patient with ambulation. The weight is distributed more posteriorly. And so this puts a lot of stress on the lumbar vertebrae, and hence they're at high risk for lumbar vertebral fractures. When you have loss of lordosis, the weight distribution is just more anteriorly, and that on its own affects the spine and makes it more at risk for fractures. Biconcave vertebral fractures are more frequent in Duchenne muscular dystrophy compared to other steroid treatment disorders, and that's probably because of this posture. And vertebral lumbar fracture are higher in ambulatory than non-ambulatory boys. Now, we have seen a lot of data on androgen therapy and peak bone mass. And this was a study that was done, which showed very interesting data, how age of puberty can affect the peak adult bone mass. So on average, girls attain puberty at age of 10.7 and boys attain puberty close to age 11.7. If you have a girl who's attaining puberty a year sooner, the increase in peak bone mineral content is about 5% more, and bone mineral density is about 2.5% more versus a year later, in which you see opposite effect. And pretty close to that, similarity was seen in boys also. And so in Duchenne muscular dystrophy, if you're having boys with delayed puberty, they're losing a significant percentage of their peak adult bone mass. And when you think of aging, every year of aging, you lose 1% of peak bone mass. So if you're starting puberty a year later, you're actually losing 4 years of your peak bone mass as an adult. So there have been studies which have shown that pubertal induction in adolescent with Duchenne muscular dystrophy has resulted in higher satisfaction. It helps in gonadotropin release and initiation of puberty, and it also increases in muscle contractile surface area. These patients were close to age 14, anywhere from 12 to 14 years. Bone age at baseline was close to 9 years. And when you look at the final bone age, most of these boys after treatment for 2 years had bone age close to 12 to 14 years, except this one who had a very delayed bone age of 6 and that advanced to 8. If you looked at the height increase, this patient increased height by 8 centimeters over 2 years with pubertal induction, and fat mass index decreased significantly, and the lean mass index increased significantly with pubertal induction of these patients. And if you look at the bone mineral density, that was variable because the study was not powered for looking at bone mineral density, but increased quite a bit in quite a few of these patients. With pubertal induction. So looking at this, I usually, if I have a DMD patient who has low bone mineral density, has history of fractures, I do induce puberty by the age of 12 years and don't wait till they're 14. If they have low normal bone mineral density but no history of fractures, then I do let them go and see if they start puberty by age 14. But otherwise, at 12 is my cutoff to induce puberty in these patients. So what are the fracture complications in patients with DMD? So honestly, when these patients have their first fracture, they cannot get out of the wheelchair after that. So they completely lost ambulation with their first fracture. And that's why thoughts about delaying fracture is very important in these patients, because they really cannot get up then after their first fracture. There's also risk of fat embolism in these patients, and vertebral fracture really impair the quality of life, especially if you have multiple vertebral involvement and they have severe pain and positioning difficulties. So fat embolism should be suspected in anyone who comes in with respiratory or cardiac symptoms after a fracture, and usually the onset is anywhere between 24 to 72 hours. And if it's not diagnosed, there's increased risk of death. The criteria for diagnosing fat embolism syndrome is any one of this major and 4 minor, or 2 major and 2 minor criteria. In the major criteria, there's respiratory and cerebral involvement along with the petechial rash, and there are other minor criteria right here. So it's very important not to think that their Duchenne muscular dystrophy is worsening, but to think of fat embolism if they're coming in after a day or two of fracture. What are the tools to assess bone health in Duchenne muscular dystrophy patients? So like I mentioned, spine x-ray is a very useful tool in these patients, especially because we know they can present with asymptomatic vertebral fractures. This is a very nice Guinan semi-quantitative method to classify your vertebral fracture and look at the severity. So grade 1, which is mild deformity, the usual decrease in height of the vertebral body is about 20 to 25%. In grade 2, it's 25 to 40% height loss, and in grade 3, it's more than 40% height loss. There are different types of vertebral fractures. You can have wedge fractures in which you see the loss more anteriorly, biconcave, which is more common in Duchenne muscular dystrophy, are in the center, but you could have crush fractures in which the whole vertebral broad body is affected. The next tool is our very old Dexa Scan. Not only does it help us look at the baseline disease, but also progression of disease and treatment. Whole body minus head and AP spine L1 to L4 are the most common sites that we look at because they have good nomogram data in pediatric population and give us more accurate information. Lateral distal femur is used in non-ambulatory or patients who have a lot of contractures and we cannot have the total body assessment. The limitation is obviously it's underestimated in short stature. So these patients who are on steroid therapy, we really need to adjust the bone mineral density for height age. And also if they have close to normal height, if they have delayed puberty and delayed bone age, and the bone mineral density needs to be adjusted for the bone age. And we must remember that a BMD z-score greater than -2 does not exclude risk for fracture. These patients can have fractures even with borderline low bone mineral density. So there's certainly a shift in standard of care in these patients. In 2010, spine x-rays were indicated only if these patients presented with back pain or kyphosis, and bisphosphonates was indicated only if they had vertebral fracture. Now moving forward in 2018, spine x-rays are indicated after initiation of glucocorticoid therapy, and IV bisphosphonates are indicated with any early vertebral signs. If there's vertebral height loss, any height loss, we need to think about starting bisphosphonate therapy and first long bone fracture, not wait for two long bone fracture. So the bone health monitoring for patients with Duchenne muscular dystrophy, this is a very nice diagram in which it says that we have to get bone mineral density test done yearly. If they're on steroid, get spine x-ray every year. If they're not on steroid, then you can delay it to every 2 to 3 years. However, if they ever have back pain or a significant decline in bone mineral density of spine, then we need to get a spine imaging. Start IV bisphosphonate and any early signs of osteoporosis, which I just mentioned, and continue bone protective therapy for a while. And this endpoint is still not determined, but usually I keep these patients on treatment till they're done growing at least. So now there are certainly thoughts about shifting the standard of care further. If maybe we should start moving towards primary prevention, meaning starting treatment even before the first fracture, because we know the first fracture really makes these patients wheelchair bound. And there are randomized controlled trials outside of United States done to look at zoledonic acid versus placebo, and I'm going to come to that shortly. But when we think about primary prevention, there are always these unsettled questions as to what point do we initiate therapy, what Z-score, what bone mineral density, and do we work with anabolic therapy too, since we know glucocorticoids are also affecting the bone formation, and when to stop therapy. There's lots of safety data on bisphosphonates that they are and have a very good anti-resorptive effect. They induce osteoclast apoptosis, and that's how it decreases the bone breakdown and increases the bone mineral density. There is a lot of data on pediatric experience telling us that it's a safe drug to use. And it's definitely superior to placebo for glucocorticoid-induced osteoporosis. And there have been studies showing that it stabilizes vertebral fracture in patients with Duchenne muscular dystrophy. This study was highly impressive to me. It talked about impact on survival with bisphosphonates on with patients with Duchenne muscular dystrophy. And this was a study done in Canada, and it looked at 44 boys. They were started on steroid therapy around the age of 7. And bisphosphonates was initiated about 12.5 years of age in 36% of these patients, and were treated for about 6 to 8 years. What was very interesting in the study was that they showed that approximately 60% of patients prescribed bisphosphonates were alive till age 24, versus patients who were not prescribed bisphosphonate, the 60% of patients lived till age 16 years. And when you look at the last patient who was not in bisphosphonate therapy, he was at age 22, and there was still 3/4 patient alive in the cohort of patients that were on bisphosphonates. So there have been recently 2 randomized controlled trials that have been published that looked at IV zoledonic acid in pediatric patients with Duchenne muscular dystrophy. Both studies were secondary prevention trials, and they had baseline vertebral fractures, and both studies met their primary outcome of significant increase in lumbar spine bone mineral density Z-score when they compared the zoledonic acid to placebo. So the first study by Zacharin was done in Australia and New Zealand, and this consists of 62 boys. 30% of these boys had vertebral fractures, and the rest were fracture naive. So they actually gave bisphosphonates to patients who did not have fracture, but just a low BMD Z score. And When you look at the increase in lumbar spine bone mineral density, there was an increase in 1.1 standard deviation at 12 months and 1.4 at 24 months compared to the placebo. And if you look at the main change in lumbar spine BMDZ score, that was also 1.2 at 12 months and 1.4 at 24 months, which showed that there was some decline in bone mineral density in the placebo group. Then there was another study done by Lee and Ward. This was done in 5 countries, two of which the major ones were United Kingdom and Australia. All these patients had vertebral fractures and lumbar spine BMDZ score of less than 0.5. They were randomized 1:1 to placebo versus IV zoledronic acid. 38% had DMD, others had some other steroid induced osteoporosis. It was seen that the difference of 0.75 increase in lumbar spine Z score was seen at 12 months in the zoledronic acid group, and none of the patients on the zoledronic acid had any fractures, while 2 patients on placebo suffered from vertebral fracture. There have been questions about oral alendronate, and I do have patients who refuse to try IV therapy and want to do just oral therapy. But when you look at the aggressivity of the osteoporosis and the need for lifelong steroid, I feel that you need to be aggressive with the osteoporosis treatment. And studies have shown that zoledronic acid is definitely more superior to alendronate when you look at the mean annual change in aerial BMD-Z squared lumbar spine. Some studies have shown that the alendronate might increase the lumbar spine bone mineral density a little bit, but the total body definitely declines over time. And there are worsening of vertebral fractures in patients with alendronate therapy. If you look at the vertebral morphometry, alendronate really does not improve the morphology of these vertebrae, which IV bisphosphonates have known to. They might stabilize some of these, but really you don't see improvement in the morphology of these vertebrae. There are questions about use of denosumab. As you all know, denosumab is a neutralization and monoclonal antibody against RANKL, and RANKL induces osteoclast formation and function. So when you inhibited RANK, it results in decreased resorption, and so it really helps increase bone mineral density. In pediatric population, however, denosumab has been known to cause severe rebound phenomena, which means when you stop therapy, the bone mineral density worsens than what you started with, and there's severe hypercalcemia that is very hard to treat and can be life-threatening. There was a pilot study done by the Ottawa Pediatric Bone Health Research Group, and this was to compare denosumab with zoledronic acid. The N was quite small. There were 4 patients who were on zoledronic acid and 4 on denosumab. The glucocorticoid exposure was much higher in patients who were in the denosumab group. The rest of the demographics were pretty similar. This was a 2-year study, and they looked at denosumab 1 milligram per kilogram sub-Q given every 6 months versus zoledronic acid 0.025 milligram per kilogram every 6 months IV. And when they looked at the change, zoledronic acid turned out to be superior in increasing the lumbar spine bone mineral density, as well as that total hip. And also the distal tibia trabecular volumetric bone mineral density was higher in zoledronic acid group compared to denosumab. If you look at the bone markers, serum alkaline phosphatase decreased in both the groups, but serum C-terminal P-peptide type 1 collagen remains stable in both the zoledronic acid and the denosumab group. So the question comes, is it denosumab versus zoledronic acid? We don't know the long-term side effects of denosumab on patients with Duchenne muscular dystrophy. This N was quite small, so maybe we need larger study population. We don't know the effect of on puberty and the muscle strength in these patients. And then how do we deal with the rebound phenomena? Maybe sealing these patients with zoledronic acid. And there are thoughts about perhaps trying that out. But again, this is not a drug you want to use at this time in patients with Duchenne muscular dystrophy. The romosozumab, that's a monoclonal antibody therapy, and it's a glycoprotein inhibitor of osteoblast WNT signaling sclerostin that it binds to and inhibits. And so it really is an anabolic therapy, so it increases bone formation. There have been studies in rats which have shown that it really increases the periosteal circumference and cortical thickness, which is quite compromised in our DMD patients. But again, this is not a drug that's been studied in pediatric population. It's been used more in adult onset osteoporosis. There are, however, studies going on in pediatric osteoporosis, OI, osteogenesis imperfecta, but we don't have data on those patients yet. So what are the other options? Are there any steroids without side effects? Well, we have an answer. Vamorolone is a drug that has recently been studied, and it seems to be a very promising drug. It's under FDA approval and is hopefully going to be approved end of this year, sometime in October. It is classified as a dissociative steroid. It's different from the other corticosteroid is that it lacks 11 beta oxygen, and so it's not a substrate for 11 beta HSD enzyme and does not need to be activated. It has less trans activation activity and more trans suppression, and in that way it's very promising because it has the anti-inflammatory response but does not have the side effect which are detrimental to bone health. So there was a randomized double-blinded 24 weeks placebo and active control trial with a 24 weeks blinded extension. There were patients who were on prednisone, placebo, and then on vamorolone 2 milligram per kilogram per day and 6 milligram per kilogram per day. There was a 4-week transition period, and then all were assigned to either 2 or 6 milligram per kilogram per day of vamorolone. The primary outcome that was looked at was time to stand velocity in vamorolone versus placebo at 24 weeks. The other secondary outcomes were 6-minute walk test, time to run, walk 10 meters, time to climb 4 stairs. The baseline demographic data was pretty similar in all these groups. The age of these patients were close to about 5 years. If you look at the baseline disease, vamorolone 6 milligram per kilogram per day were more severely affected. Only 12% of the patients could pass the 6-minute walk test distance of 350 meters, while the percentage was much higher in placebo and prednisolone and the low dose vamorolone group, showing that they were less severely affected. When we looked at the time to stand velocity in this study, you can see that vamorolone 6 milligram per kilogram per day versus placebo, the time to stand velocity, the difference was 0.06 rises per second with a p-value of 0.02. And time to stand velocity was described by this picture. If you see, it's the time that takes for the child to be in the supine position and then turn over, roll over, and stand up. How do we interpret this difference? So a difference in 0.05 rises per second predicts a delay of 2 to 3 years in time of loss of ambulation, which I thought was pretty impressive, as usually these boys lose ambulation by age 10. When we looked at the motor outcomes in the study, vamorolone versus placebo, you can see the time to stand velocity was much higher in the 6 milligram per kilogram versus 2 milligram or placebo. The 6-minute walk test was much higher in patients on vamorolone, either dose versus placebo. And time to run was much higher on the 6 milligram per kilogram per day versus 2 milligram, and then much lower in the placebo group. This is a nice chart that compares vamorolone to prednisone, if you look on the right side, this favors prednisone. So vamorolone 6 milligram per kilogram per day has pretty similar effects to prednisone, while vamorolone 2 milligram per kilogram per day was inferior to prednisone. Looking at some of the side effects, if you look at vamorolone, 6 milligram per kilogram, which was the dose that worked for the muscle disease. They did have less behavioral problems compared to prednisone. However, they had higher Cushingoid features and higher weight gain compared to prednisone, which was a side effect of interest. If you looked at the bone markers, all of the bone markers remained pretty stable, and there was no suppression with vamorolone. And this, I think, is a very interesting slide because if you look at all the bone formation markers, osteocalcin, procollagen 1 and terminal propeptide, and type 1 collagen TTLopeptide, all of these bone markers were suppressed when these patients were on prednisone, and switching them to vamorolone causes reversal of these bone markers, indicating a new bone formation. If you look at the height change from baseline, the vamorolone 6 milligram per kilogram group had an increase in height percentile versus the prednisone group. And also, if you look at the weight gain, there was slight increase in weight gain, but I don't think it was that dramatic in the vamorolone group. If you look at the immediate reversal of the height Z-score decline following transition from daily prednisone to daily vamorolone group, you see a significant rise in height Z-score. So there's an immediate reversal when you transition these patients from prednisone to vamorolone. The spine deformity index, which is some of the Gannan classification on the spine X-ray, you can see that on the vamorolone group, the spine deformity index was much lower compared to daily prednisone and the daily deflazacort group. If you look at the prevalence of vertebral fractures, that again was significantly lower in the vamorolone group, 13% versus 27% on the prednisone daily, and deflazacort daily had 30% prevalence of vertebral fractures. So to conclude, bone health screening starting early is crucial to prevent long-term complications in patients with Duchenne muscular dystrophy. AP spine and total body and AP spine L1 to L4 Dexa scans are very important screening tools. Treatment with IV bisphosphonates with any vertebral body changes of first long bone fracture should be initiated with thoughts of starting therapy even before the first fracture. Consider treating for very low bone density on Dexa scan. Vamorolone does not appear to suppress bone turnover markers. It has favorable impact on growth. Lower vertebral fracture burden is seen than daily deflazacort and daily prednisone treatment. Vamorolone may be relatively bone sparing in ambulatory boys with Duchenne muscular dystrophy compared to classic daily steroid. Obviously, we need to see the long-term outcomes, but I think it's a very promising drug and certainly needs to be on your thought to start patients, especially Duchenne muscular dystrophy patients who are having a lot of fractures and low bone mineral density on conventional steroid regimen. Thank you.
Okay, thank you.